everyone. This is the 8th in our resiliency webinar series, presented live, generally the 2nd and 4th Thursdays of every month. Mark your calendars for our next webinar, which will be held on Thursday, October 22nd at 1 p.m. With author, emergency physician, and foundation board member, Dr. Shannon Salvendal, in a conversation about the power of positive in a fragile world. Today, we're excited to be hearing from Sherri Dean and Dave Motzkin on the importance of establishing peer-to-peer support systems. They'll be sharing with us the value of the peer-to-peer support system, support team, to PHI Health as a whole, and what went into the development, evolution, data, culture, and lessons learned, and investment ROI. Reminder to our live attendees, if you have a question to pose to our speakers, use the Zoom Q&A tool provided when you think of it, and we'll queue those up. And as soon as we are ready for Q&A, we'll get those read aloud and answered live. So what we'll be talking about today, again, that's going to be the peer-to-peer system. So as Executive Director of the MedEvac Foundation International, and on behalf of the board, staff, volunteers, and especially our donors who collectively make this taking care of our own Help is on the Way programming possible, we welcome all of you. We've had more than 80 people register for this webinar, and we know that hundreds more tune in on the archives when they have the opportunity to do so on their own time. So if you're joining us after the fact, thanks for seeking this out. Now, we'll have Jared Hughes, our Development Director, introduce our speakers. Jared?
Thanks, Garrett. Before I introduce our guest today, I want to make a pitch for our Run to Help the Helpers. It's an annual run, walk, roll, swim, golf challenge that started in May, and it's running through the end of the year. We currently have 178 participants so far, with people signing up for one of several events available for all abilities, from a 1-mile family fun run to a 1,000-mile cycling fundraising challenge from our board chair, Howard Ragsdale. I want to give a special shout out to our many individual donors and corporate sponsors to date: Metro Aviation, Lifelink 3, Apollo Medflight, Cames, and most recently, Southside Hospital in Bayshore, New York, that came on this week as a bronze level sponsor. You can sign up to run yourself or sponsor the mileage of one of the participants at the medevacfoundation.org or by Googling Run to Help the Helpers. Now to our speakers. I'm honored to have Sherri Dean and Dave Motzkin with us today. As Director of Ambulance Operations for PHI Health, Sherri Dean oversees all air ambulance services as she works with leadership across the country, ensuring a consistent culture that embraces safety, clinical quality, and service. In addition, Sherri is the senior leader of PHI's peer support and critical incident team and has been instrumental in the team's growth and presence within PHI, as well as extending out to their customers. Sherri's career began as a transport crew member for a ground helicopter and fixed wing program and progressed quickly to hospital administration before serving as a VP of clinical services for a multi-aircraft HAA provider. Sherri is responsible for researching, developing, and executing business plans for PHI while keeping in mind national and state legislation and regulations that impact our industry, as well as to develop, maintain, and promote positive and productive relationships within her health system counterparts. This ensures the commitment each partner has to its own mission and values. Dave Motzkin is president of PHI Air Medical and is a recognized leader in the air medical industry, having been a part of PHI's leadership since 2004. In 1985, Dave joined Rocky Mountain Helicopters and, as the Arizona-based director, helped establish the LifeNet brand. In 2002, he became a member of Air Method's leadership team via the Rocky Mountain Helicopter acquisition. He began his career over 30 years ago in public safety, working as a firefighter and a paramedic. Sherri and Dave, we're thrilled to have you both with us, and we're grateful to you for both your life's work. Thank you again for PHI's leadership and your loyal philanthropic support during the pandemic of MedEvac Foundation International. Dave, the floor is yours.
Thanks, Jared. Good morning, everybody. We wanted to start off first with addressing the name of our program. We call it our peer support team. In history, that used to be our critical incident response team. And it's a funny thing trying to get first responders to admit that they are having a personal emergency, or to get them to rate an event is actually critical in the way that it has impacted them. It's really a misnomer. Our best work is actually done on an ongoing basis through education and the regular supporting of one another. And our flight paramedics, flight nurses, pilots, communication specialists, and the most forgotten group, the patient financial services team, who are dealing with our patients and or their families after a tragedy, and they end up almost becoming telephone counselors. Each of those folks has the opportunity to lean on one another on a regular and daily basis, to remind each other of the important education of the program, and to watch out for red flags when other members of the team may need to be brought to help. That ongoing work really doesn't fit the name Critical Incident Response Team, which I think harkens back to a time when you would have a bad event and a defusing and debriefing would occur within 24 and 72 hours. And while that type of work is still necessary, it falls far short of the real work of the peer support team, which is done every day. So just starting with the evolution of the name, we do call it our peer support team. And while they do engage in critical incident response work, it is by far not the lion's share of what they do. Moving on to what inspired the team. I think that all of us that have been in this profession for any amount of time has had to seek resources in times of need, either for ourselves or for a coworker. And over the course of time, there has been teams made that were available on a regional or national basis. Sometimes they were from multiple agencies comprising a team. But what we found is we found a moment in time where available community resources, available regional resources, available national resources were not effectively meeting the needs of our staff. It became very apparent in the face of a few sentinel events. One was the recognition and the continuous reporting on the rate of suicides for first responders and for care providers, reaching up to 600% of the national average. Then we look inside of our organization. Since 2004, PHI has had 10 suicides. That includes the entire PHI enterprise, oil and gas and air medical alike, but the lion's share of those suicides have been on the air medical side. Interestingly, if you were to look at official records, it would say, I think 7 rather than 10, because it didn't take into account folks that had real performance deficits and whose employment was terminated, and within hours or days after separating from employment, they ended up committing suicide. I don't think it's a fair representation of the issue unless we bring them in. Some of my greatest insight comes from the 10th person on the list who is alive today. And the reason I count them in the suicide is because they fully committed to killing themselves. They broke open a medication refrigerator. They started a HEP lock on themselves, and they literally dumped the contents of the refrigerator into their veins, and they were in a position where they required resuscitation. Fortunately, the tones went off indicating a flight. The crew went looking for their missing crew member, and they found them, and they were able to successfully resuscitate the person who's alive and well today. It's one of our most valuable resources to talk to a person that has actually gone all the way through with the act of suicide and then lived to tell about it. and to share what some of their needs are, and how systematically we could better approach providing care and support to these folks. When you're preparing to build a team, there's much to be considered. I will attest that having the team is expensive, and I will also attest that it is a great investment, and then its return, both altruistic and financial, is exceptional for the organization. So while expensive, I wouldn't hesitate to duplicate this team again, given the opportunity. There's some things that are going to be somewhat provocative that I want to bring up, that watching this team perform and watching the evolution of staff over time has really shown bright lights on. And one of the provocative topics is not everybody's cut out for this job. Not everybody that wants to be a pilot, EMS pilot or a flight nurse or a flight medic really belongs in that career path. There is a level of grit and perseverance and resiliency that is innately required in an individual to do this career for a long time. And even those folks are going to need help along the way. But if you start off hiring people that in less politically correct forums, they might be referred to as snowflakes, people that are very fragile of sensitivity and of mind. When we bring these people into the workforce, we're setting them up for failure. Not unlike hiring somebody that has a bad back, knowing that they are going to have to do motor vehicle accident extrications and lift patients. You're setting yourself up for back injuries. When you bring people into the workforce that lack natural resiliency, you're setting up a chain where the amount of help and support that those individuals are going to need may actually outtask the system. And even with the best the system has to offer, it may not be successful for them. They just weren't the right fit. This follows a model called behavioral competency hiring. And behavioral competency includes things that are familiar, like does the person have integrity? Can they be a team player? Do they have high professional standards? Are they able and willing to give and receive feedback? These are common hiring traits that we look at. But are we looking at, do they have grit? Do they have personal resiliency? Do they have the ability to ask for and receive help from a group like the peer support team and produce a great outcome on the backside? Looking at the trend nationwide in our first responders, it begs the uncomfortable question of motive. Why are you lining up for this job? Are you intending to be a servant of others? Do you think it's a pathway to become a hero? Is it a pathway to become a victim? And are those healthy motives for entering this workforce? So the best way to set your peer support team up for success is to first make sure that you're adding people into the workforce that have at least the basic capability of grit and resiliency, and that when faced with challenges that may be overwhelming to them, are they coachable through the peer support process to a successful outcome? So just to get the uncomfortable part of the conversation on the table first, you got to have the right people. And then once you do, there is still a need. I look at suicide, particularly amongst our first responders, and you think that the person has a set of problems, and suicide has become a option on their solution set list. If you interview enough first responders, you'll find that it's probably been on the list for more than you could ever imagine, but it's been really far down on the list, and it's really never risen up high enough on the list to be a threat or a concern. Is there a way, when you're looking at specifically suicide reduction, is there a way to identify folks that have suicide as a solution set higher up, or particularly high up on their list of solution sets? And do they have the resiliency to do a job like this without it becoming the #1 solution? If you're feeding folks into the workforce where suicide is too high on their list of solution sets, or they lack basic grit and resiliency, you're handing your peer support team a challenge that they cannot conquer. Moving on to the next topic on setting up the team, our pilots have a unique and particular challenge of FAA reporting. When they interact with certain types of professionals, it may be reportable to the flight surgeon when they're renewing their medical. We have moved our peer support team to a training function. It's that proactive education on grit and resiliency, and then healthy mechanisms to manage when you're overwhelmed, and your grit and resiliency has really been outweighed by either acute or cumulative stress, and now you're reaching out for the peer support team. By moving it into training, our pilots are able to honestly look anyone, the FAA, a flight physician, they could look anyone in the eye and say, I attended training, rather than I had an interaction or an intervention with a team that might line up on the medical side of the equation. And I can tell you that our statistics prove that we had a dramatic lack of pilot participation until we made the training element clear. And then the numbers came up in a very meaningful way with pilot participation. So structuring your team, peer support versus critical incident response, recognizing the ongoing work rather than the acute stress work following a call, financial implication and return on investment. I will tell you that it's more than worth it altruistically and financially to support a good team. Bring the right people into the organization. Screen for basic resiliency and basic grittiness, so that you're not bringing folks in that don't have the natural ability to survive what they're going to be exposed to, even with the help of a peer support team. And then moving forward from there, appreciate that once you know of a problem, now you have to be prepared to do something about it. The peer support team in its good works will identify people that at least in the moment are not fit for duty. And you're going to have to be prepared organizationally to have the knowledge that someone's not fit for duty and be prepared to support them. Whether it's through PTO, sick time, paid leaves of absence, there has to be a structure in place where when somebody is truly in need, you're able to support them. Sending somebody off on leave without pay because they're not fit for duty will do nothing but drive down participation in the team and increase the number of folks on the front line that are not fit for duty. So again, organizational support is not just about building the team, being willing to pay for their time and their training, having a great medical director to lead the team. Set all of that aside, once that team discovers somebody in need, you have to also be prepared to support them. one of the more eye-opening components for me was the amount of support folks need at different times. We've recently dealt with a case through the peer support team where what the person needed more than anything was a mode of transportation to get back and forth to places where they could receive help. And the event that kind of pushed them into harm's way also destroyed their motor vehicle. So as an organization, we chose to step up and rent a car to bridge the gap to get them where they needed to go. The list of little things that come up that are going to require the organizational support really doesn't have a limit. Sometimes it's dropping off food, providing childcare, in this case, a rental car. Once you identify and discover that somebody is in need, you have to be prepared to follow through on the back end. Last but not least, don't forget that the work of your peer support team also puts those individuals in jeopardy. You can't just build a team and believe that, number one, they can carry the burden of others forever, and that they themselves may not have needs based on that additional exposure to the suffering of others. So as you're building the team, also build a mechanism to take care of the team. As a high-level overview, that concludes my forward comments. I'll pass it back to Jared.
Well, actually, Dave, I think what we'll do is Sherri, if you want to share a few comments. After that, I've got some questions that are teed up, but I thought I'd offer you the opportunity to share some things before we go right into those questions.
Sure, absolutely, Garet. Well, as they mentioned, I oversee kind of the day-to-day of the peer support team that PHI has developed. And we actually began our team in 2011. The first step of that was selecting a medical director, which Dave has mentioned already. Once we selected the medical director, we went on to the development of the individuals who would make up the team itself. And we've learned some lessons along the way, which is to be expected. One of the things we learned, as Dave talked about, hiring the right people, selecting the right people for your team is critical. So initially it was more of a volunteer basis. As we were in our infancy, we were really learning what the needs would be, what the demand would be. And where we are today is we ask for either volunteers or recommendations of individuals who would like to be part of the team. And we do have a multidisciplinary team currently. It's made up of about 25 members, and that ebbs and flows, but we generally run around 25 members. And they are made up of clinicians, administrative folks that support specifically our PFS department, and the individuals who work in our corporate office and are also facing challenges that result in acute or cumulative stress. We have communication specialists, mechanics, pilots, all aspects of our business is reflected in the peer support team. Individuals who are interested go through a screening process, and they have to have the support of their immediate supervisor in a written form, a letter of support. And then we also conduct some of the behavioral-based interview questions that Dave mentioned, and our medical director participates in that. Once we have those individuals selected, there's about a 3-day training that they go through initially with our medical director. And during that time, they are learning all about the physiologic impact of stress. So many of the people who make up the air medical or the critical care transport industry are very science-based, type A personalities. And so understanding why the responses are the way they are, simply from a physiologic perspective, takes away that fear of it being something that makes them look weak if they reach out for help. If they understand this is a physiologic response to events that they have participated in or been part of, then it's easier for them to reach out. So we complete about a 3-day training, and then annually we do about a 2-day, generally in person. This year, obviously, it will be virtual, but bringing the team together. And that is the recurrent training that we require that they participate in. But it also is really good for what Dave mentioned as far as supporting the people and creating that network and that cohesive, the unity that they require for the team to be successful, because they cover coast to coast. And so many times the only time they see their peers on the peer support team is when they meet in person for that annual recurrent training under the direction of our leadership and the administrative team that oversees the peer support program. So selecting the right people is critical. One of the things that we also learned in the process is we believed that we were doing good things, but at the beginning we didn't have any data to support that. And we wanted to really be able to reflect the value to the organization as a whole. So we began in about 2013 collecting just very general data. Discipline, the state in which they reside, the length of service that they've been with PHI and been in the EMS community. And that helped us tailor how we got the word out about our peer support team. And one of the things that we identified is we had the team for many years, but across the organization, many people were unaware that we had this. They didn't know they had this resource available to them. So we began weaving in education about the peer support team from the new hire academy immediately upon onboarding. And then that was continued for the first about 180 days at various check-in points with all new employees. And Dave talked about making it an education aspect. And so we also, those peer support team members also are responsible for ensuring that at the base level, there's annual education on the peer support program, on acute and cumulative stress, on the resources that are available to them at any given time. And that's really evolved now where, as he mentioned, we're incorporating resilience. So taking a more proactive and preventative approach to, it's not if we're going to deal with stress and those crisis situations or critical situations, it's a matter of when. So if we can arm our workforce with the tools and the tips and the tricks that will allow them to more successfully navigate through those situations as they come up, then everyone is in a better place. They are as individuals, they are as employees, they are as just general human beings. So that has become part of that annual training. And what we identified in those metrics early on, it's been interesting. Initially, it was individuals who had been with our company or at EMS for about 7 to 10 years. And now we are seeing a significant increase in the number of employees who are reaching out that are in the 0 to 3 years with our company range. So that demonstrates to us that we've been successful in increasing the visibility and the value of the program that we have for all employees, regardless of what business unit or what area in which they work. We also have really looked at how do we reduce the stigma associated with asking for help. Again, those type A personalities, it can be difficult sometimes to acknowledge that help is needed. Frequently there's the attitude of, well, I believe in it, I think there's value, but not for me, it's for other people. And so Dave talked about the name of our team, which is the Peer Support and Critical Incident Team. For many years, it was the CISM team or the CIRT team. And what we found as we talked to people, generally there was a delayed period of time between the event that had transpired and them seeking help for whatever reason. And of course that delays the opportunity for them to move to a healthier place when there's a delay there. And what we found when we were talking with people is that they didn't think that the event that they experienced was critical enough. So critical is a very subjective term. My definition of critical is very different than someone else's definition of critical. And so people didn't want to burden the system or label their event as critical when their partner or the other people who were perhaps involved with that flight didn't think it was a big deal. So they didn't want to reach out. And so in about 2018, we rebranded the team to really make the emphasis on peer support, because in reality, 99% of the interactions that we have are simply peer-to-peer, and they are not an activation. It is not multiple people responding to a large-scale event. And we found that when we changed the image of the program, even though it was exactly the same, the number of individuals who felt more comfortable reaching out increased significantly. Along with that rebranding, and Dave has mentioned already, is the buy-in has to come from the top. We had the opportunity to create a video that highlighted Dave's support and the organization's support of the program, and the value of reaching out and getting some support and assistance from your peers at any time that is appropriate for those individuals. And when we did that rebranding, we saw a significant increase in the number of interactions. People felt a lot more comfortable reaching out when it was just a peer support, as opposed to having that word critical incident tied to the team. So that was a significant difference. And along those lines, we had people reaching out more, but we also had people reaching out more for events that weren't necessarily peer support related. So we had to go back and do some education with the team on what's the difference between an EAP referral versus a peer support referral for the workplace. And we spent a lot of time providing education there. And so an example of that might be someone is struggling at work because of a financial issue. And they're struggling at work because of the financial issue that's a home issue. And what we found is many organizations offer EAP, but that can also be an intimidating and a cumbersome process to navigate. So we worked with those peer support team members to script the conversation so they understood how to relay that difference to the employee without negating or diminishing what the individual was going through. And we also taught them how to navigate our corporate EAP program so that they could guide the employee through that. And that helps significantly in taking away some of the fear with accessing some of the resources that are available, but also protecting those 25 team members and not having them have additional responsibilities beyond peer support that really weren't what they were trained to manage. So that's been a really big aspect for us as well. In 2020, of course, we've seen a higher number of reach outs. Many of those are COVID related, and since March, actually 100% of the interactions that we've had have had some COVID component to it. And what we've really identified is that as many are seeing, the overall stress of COVID has really challenged everyone's ability to cope. And so things that in the past might not have been significant in the workplace is now becoming significant. And whether it's the social distancing being practiced, whether it is the burden of all of the PPE that our employees are wearing all the time, there are a lot of factors weighing into that. And we're doing everything we can to support those needs as they come in and help people adjust to the way the work environment is at this moment. And we don't know how long it's going to last, but we have seen a significant uptick in the number of reach outs to our peer support team.
All right, well, Sherri and Dave, thank you so much for sharing all of that information. We've had quite a few questions come in actually, and I think what I'll do is I'll start with Dave because I've seen from several people variations on the following. You know, how do you screen for grit, or how do you measure it and kind of measure for resiliency during an interview? And of course, we know hiring practices being what they are, different in every state in terms of the rules and regulations. You know, you have to be somewhat careful about the questions that you ask, but I think that this is a really great point. So if you could talk a little bit about what you've done to measure that in the interviewing process, I think that'd be great.
Sure. first acknowledging the fallibility of interview processes in general. There's an old saying that I'd like to think we're a little better than this, but you craft a perfect onboarding process and you've raised your chances all the way to a 50-50 on whether or not you get the right person. I'd like to think that we do a little better than that. Our statistics suggest that we do, but it's certainly not perfect. And I do want to clarify that once they're on the team, whether they should have been or shouldn't have been is no longer a factor. We take care of them just the same. But to answer the question directly, we ask specific questions about, have you ever had a circumstance that took you to your breaking point? And then for probatives, how did you handle it? What did you do about it? How is it affecting you today? That is one sample question of assessing someone's grittiness. You can tell in an interview whether or not you're getting a complete, heartfelt answer coming from wisdom or experience, or whether someone is making up a hypothetical to try and fill the answer in which case we'll flip the form of the question and ask about their observations of someone else's resiliency. When have you seen a person who was pushed past their limits? What did it look like? How did they behave? The other thing that you look for is the signs of victim-based answering. When we look at the folks that produce resilient results, the folks that see their own work as heroic, and people that see themselves as victimized by their work typically are not the folks that are more resilient. Folks that see themselves as a servant of others tend to be the more resilient of the workforce. So those are some of our tells in an interview.
No, that's great. Thank you for that, Sherri. The next question is for you. It says, how do you tell people they are not suitable for the team?
Sure. Well, I want to back up a little bit and point out some of the traits that do make a good team member. Dave talked about the servant mentality, and that also translates over to the peer support team. So many times people will have a desire to join the team because they can talk to anybody, and that includes like a doorknob. They don't have to have another person there to participate in the conversation, and they can talk. That is not the ideal peer support team member. Being part of the peer support team is about actively listening and being engaged and respectfully asking hard questions and doing it in a manner that's non-threatening. So the way that we tell people who may not be a candidate, number one, if they don't get a letter of support from their supervisor, I spend time with the supervisor coaching them on how they might be able to have that difficult conversation with the employee as to why they don't have their support today, but how they may improve so that they could be considered in the future. And I think that's really important. And sometimes it's a matter of, confidentiality. And if you are comfortable sitting around the table following a crew briefing and talking about all the things that the previous shift didn't do, or all of the things that ground EMS crew when you're on a flight did wrong, that's not the personality we want. We want people who are there to support from a positive perspective. And so we will have the conversation about how they may be perceived by their peers, or ways that I like to focus on the things that they can do to make themselves a better candidate for the future, as opposed to all of the things they did wrong. Sometimes it's just because we have enough, like for example, there are times when we will have 8 pilots want to be part of the team, and we really don't have a need for that many pilots, because one of the things that we do, and the reason we have a multidisciplinary team, and the reason we keep it fairly small, is as leaders, when we receive the notification that someone is seeking to talk to one of their peers through the peer support team, we try to align that individual with the same discipline. And we also try to find a little bit about them so we can align them with someone who is relatable to them. And so through that process, people have to be able to establish a rapport via the phone, because the majority of the time when someone is reaching out for peer support, they do not want to talk with someone that they are going to be working with or running into day in, day out at their base or in their local region. So we generally align them with someone outside of their region because they're more comfortable talking with them. Like I said, the vast majority happen by phone. So when we do the interview, we're also able to determine how quickly and how authentically the candidate can establish a rapport with someone, with people or a person that they don't really know. And the beauty is that many people who are in this environment are very, very good at doing that. You know, whether you are a flight crew member and you need to quickly establish rapport with a referring or receiving hospital or an EMS agency, those are things that are typically in the wheelhouse of the majority of our workforce. But that is a very critical component. So in our conversations about why someone isn't a candidate, it's focusing on how they can become a better candidate. And it's also being truthful about, this is just about, we don't have any more, we don't have the need for additional pilots or communication specialists, but we have you in the queue. There were people who scored a little bit higher. These are ways you can continue to prepare yourself to be part of the team in the future.
No, that's really great. Thank you for that as well. Lots of other good questions here. One is, do you do any second victim training? Another, and this is one that I think might be related to it, but do you include the suicidal employee's family in the trainings?
Dave, were you starting to answer that?
Yeah, I knew what he meant by second victim training. The answer is typically no. Sometimes it's the family dynamic that is at the heart of the problem. If we refer a person out to a higher level of care, a higher level of mental health care or counseling care, that care provider may elect to or not to include family or secondary victims. But our initial response is typically not focused on secondary victims. And Sherri, jump in if I've stepped out of line.
No, that's accurate. But I will say that we have done reach out to family members, not based on the individual, but we sent out to the home a mailer introducing the peer support team and letting families know how to contact the peer support team in the event they are seeing behavioral changes in their significant other or their family member that has them concerned. And we do get a fair number of spouses who reach out to the peer support team on behalf of their loved one because there are concerns, and that does happen fairly regularly.
Thanks for that. One other that I see here is if you identify someone that needs or requires support but refuses the help, how do you manage that situation?
You know, we do have that come up on occasion, and we don't have it happen very often, and generally with conversation, people become more open to the idea. What we found is typically when individuals are not comfortable receiving help, it's because they have misinformation about what it means. And so the way that we have several different avenues in which the peer support team can be activated. And one of those is through like an 800 number. And that rolls to, that's a leadership, a manager or leader receives that initial call. And the person who is calling is oftentimes not the individual that has been identified as potentially, going through something tough and needing peer support. And so what we always encourage, that it might be a supervisor, it might be their partner, it might be a coworker that they work side by side with in the office here. And what we really encourage them to do when we provide coaching for them on this is for them to have a conversation. We always will say, does XYZ know that you're calling on their behalf? And when they say no, we ask that they have a conversation with them, letting them know what they've seen, what their concerns are, and how they would like to help them. And the peer support avenue is the way that they would recommend. And 9 times out of 10, just having the courage to have that conversation opens the door for individuals to say, okay, I will talk to someone. In the event that someone is unwilling, even after education and discussion with someone that they know and trust, we just try to keep an eye on them. And if there are behaviors that become more concerning, we will reach out with potentially a different individual, might try and contact them and see if they're willing. But we have people who say they're willing and then they don't take phone calls or they won't respond to any kinds of messages. And we just make a note, and we do not invade or force them to interact with us.
Yeah, great.
And then I'll jump in. I'll jump in on that and say, if it rises to the level where we can assess from the outside, looking at the individual impacted, if we can assess they're not fit for duty, then administratively we'll step in, take them off duty, and then provide the pathway to come back on duty, which is going to require some form of engagement with either occupational health or the peer support team. So if the behavior is observable enough where it's actionable, we will step in from an administrative perspective and remove people that are not fit for duty, and then craft a pathway for them to become fit for duty. If the behaviors are violations of our conduct expectations, then respectfully, through a just culture, they are still held accountable for those aberrant behaviors that are unacceptable.
No, that's great. And thank you both for sharing. This one actually, we'll start with the first question. There is kind of a sub question that I think is related to this, but do you do any type of an employee survey annually to provide the company with information on the well-being of all employees? I don't think you answered that exactly before. I know you talked a little bit about metrics, but I'm just wondering from this question, you know, again, overall, do you do something annually to assess well-being?
The direct answer is no. We do surveys about the effectiveness of the peer support team. It's not annual, but we do not conduct an annual wellness survey.
Okay, great. So then part of this still slightly related, but slightly different as well. So how do you determine someone has suicide as an answer for a solution, and how do you arrive at that conclusion? What questions do you ask? Is that what you were getting at with that idea of the breaking point question from an interview perspective?
Yeah, so we don't specifically dig for the suicide answer in an interview, but surprisingly, when you ask some of the hard questions about, you know, have you had a situation that's pushed you to the point of being overwhelmed? What was your process for getting out of it or becoming well? It effervesces, or it comes up as a solution set. We don't specifically dig for it, but it is interesting in high volume interviewing the number of times that it does come up.
Great. Let's get to some of the other brass tacks questions that have come through. So can you estimate the budget every year for the peer-to-peer support team education? So for instance, for X amount of employees, we have budgeted X amount per employee for this. Sherri,
do you have that top of mind?
Well, I don't have the number top of mind, but essentially when, for the annual training or the initial training, we budget for the number of employees on the team, their hourly wage. And because we cover coast to coast, there are also associated travel expenses that are tied in with that. So there are, depending on the size and the spread of a program, that's something that really could be done in-house along with education. And then we have our medical director as well, which has the usual and customary compensation for medical director duties. And then as far as education at the base level, we incorporate that into our already planned and scheduled base meetings, and they just get on the schedule for the peer support and the resilience annual education along with our online education platform. So it's tied in with education that we budget for throughout the year.
Wonderful, wonderful.
And Garet, I'll jump in there and say that for a 25-person team where they are, with the exception of the medical director, they are employees of the company that have a full-time job, and we're paying them extra wages if they're called out from a peer support perspective. The cost of the team runs at about $110,000 a year. That does not include supporting people after the fact, the rental cars or a referral out to another expert, not including that, just the basic running of the team, 25 people, the over and above cost is about $110,000 a year.
Excellent, thank you for that. What are the common issues that the peer-to-peer support team deals with? The most common issues, I should say.
I would say that the most common issues, it depends on what discipline they are. So the clinicians, primarily what we hear from clinicians on is pediatric patients that have a bad outcome. That is a very big trigger for folks. So clinical issues that are the extreme, whether it is a child, whether it's a neonate, whether typically those are the patient care related ones that we see most often. On the aviation side with the pilots, many times it is a flight that they had that the patient was someone that they are directly relatable to. For example, they flew an adolescent who they landed on a scene and they have the exact same make and model of the pilot's child's vehicle, and it strikes them very close to home. It also may be an operational event. For example, if we have an aircraft go double IMC, or that they're flying in visual conditions, but unexpectedly they wind up in the clouds. That's one where we hear from pilots on those occasions. They're trained for those events. They exercise that through annual training on a regular basis, semi-annual training, but that's something that they would reach out. On the PFS side, this is something relatively new in 2018 when we began incorporating the administrative team that supports our operations as well. Our patient financial services are talking with the families and the loved ones of the individuals that we fly after the fact. And those can be very difficult conversations for them as well. And so the number of individuals reaching out who have had a tough conversation with a family member those numbers are not small. And along the same lines, our communication specialists, when they have the call where they are feeling like they wish they could have done more, whether they could or couldn't have, or it strikes a chord with them for whatever reason, we hear from our communication specialists on those as well.
Great. We're nearing the end, but we do have a couple of more questions. So how do you deal with patient employee adverse events in the peer-to-peer support system?
So we really work to separate out the clinical aspects of the flight, and we teach the team to focus on what the employee is feeling, what their fears are, what their concerns are. We work really hard to help normalize that behavior. So it's normal for after a flight that was your first flight where there was a big adrenaline rush for you to feel nauseated. And this is why you feel nauseated. This is what's happening in your body from a hormone response to the event that transpired. So we try to really separate, and we teach the crew members how to open the conversation up and focus on themselves as the provider, as opposed to the technical aspect of what they did with the patient. We do have the situation come up where we have people who are on a corrective action plan and they start kind of throwing some Hail Marys and they reach out to the peer support team in the hopes that they will be protected from being held accountable. And we generally can discern that very early on. And when we have a question about that, you know, the leadership group will become involved and help kind of vet that. But that happens on a fairly regular basis. But to answer the original question, we really steer the conversation so the individual is talking about what they feel and where they are, as opposed to, you know, ticking off all the things they did on the flight in response to the patient that they were caring for.
Awesome. And I think we'll ask one last one here. So what are the key components of the training program? I mean, you've talked a lot about exactly what you all do, but what do you really find to be the key components of the training program?
The key components are the education about, like I mentioned earlier, physiologically, what is happening, defining the different kinds of stress, reviewing the physiologic response to the different stressors that we experience in the job that we do every day. But along with that, we also go through active listening. They go through basically scenario-based training where they, you know, one of them will be the person reaching out for peer support or be participating in an activation, and the other is the listener, and we'll reverse those roles. A lot about, it's primarily about how the EAP piece of it we talked about. So how to really listen and guide and ensure that we are the appropriate people for them to be talking to, and then also how to manage that conversation and the different types of personalities that come into play and how to best communicate with people. So it's really all about communication and most specifically listening.
And I'll add to that, recognizing that there is a problem that needs addressing, and way at the top of the list is absolute impregnable confidentiality. If your peers don't trust you to keep it confidential, the system will fail.
Well, thank you both for your time. This has been an absolutely wonderful discussion, and hopefully folks have been able to take lots of notes. I know that we had a lot of questions come through, and I think we answered all of them that we could in the time that we have. Really appreciate you all taking the time today to share what you're doing with PHI. Thank you for your loyalty to the MedEvac Foundation International. We really appreciate it, and hope you all have a wonderful rest of the day. Thanks so much for joining us.
Thanks, everyone.
Thank you.
Take care.